Good morning or good afternoon, everyone who's attending our session with us today, depending on where you're joining us from on this beautiful Saturday, March the 13th, 2021, for this Syrian American Medical Society sponsored discussion and lecture. Let me tell you this, just to get things started. Thank you for taking time on your weekend, but you are in for a big treat. Very big treat, because guess what? Today, all you need to know about COVID vaccines will be presented today by our very elegant speaker, Dr. Diane Birnbaumer. Dr. Diane Birnbaumer, she is a board certified and residency trained in internal medicine and emergency medicine. She's actually emeritus professor at UCLA Giffen School of Medicine. She's actually a senior clinical educator too at the Department of Emergency Medicine at Harbor UCLA. She impressively presented more than 2,500 lectures nationally and locally. Thus, it's no surprise that she went ahead and earned the American College of Emergency Medicine Outstanding Speaker of the Year Award, and that to be followed with the Lifetime Education Award at Harbor UCLA Department of Emergency Medicine. And as she goes through the discussion and present the topics today, she will, so the structure of the talk today is going to be, the initial part is the live presentation by Dr. Birnbaumer, and then afterwards, and as she's discussing those topics, feel free to submit your questions. We're not going to address them right then and there. We're going to collect the questions, and at the end of the talk, we're going to have an ample time to go over every single question and get a live feedback and answer from Dr. Birnbaumer. By the way, forgot to introduce myself. I'm Anas Kawai. I'm a gastroenterologist here in Southern California, and I'll present the virtual podium to Dr. Birnbaumer.
All right, hi everybody. Well, I'm going to have Dr. Kawai, if you don't mind muting yours. There we go, perfect. Okay, I really appreciate this, and I hope we have enough people that join that make it worth everybody's while. Thank you for taking your time. I'm only going to take an hour of your day, but I promise you I'm going to make it worth your while. You're going to be able to leave this talk today, be able to answer anybody's questions, friends, family, patients, anybody that comes across your path. You're going to be able to answer their questions when it comes to the COVID vaccine, and maybe even questions you have for yourself about these things, because it changes every day. And I've updated these slides literally every day for months. So let's talk about updates on coronavirus. And I have no disclosures. I have no financial involvement anywhere on this thing, but I do have a little bit of a disclaimer in that this has been a head spinning year. Everybody who's on this call today, none of us knew a year ago. It was a year ago on the 19th of March that California, which is where I live, was shut down, where our freeways were empty. It looked post-apocalyptic outside. None of us knew what this virus was going to do. None of us knew how many people were going to get sick and die. None of us knew how to treat this thing, how to treat people who were sick. It was just, if you think about it though, what we've done in a year, what we've done internationally in a year, what we've done in science in a year, it is remarkable. It is remarkable. Every disaster, every tragedy, every things like a pandemic is a chance for change. And there's been a tremendous amount of change that has come of this in medicine and in society. It's a chance to restart certain things. It's a chance for science to really show its glory, because the science of vaccines that has come out of this pandemic is absolutely remarkable. So the changes though are head spinning. And I think what I'd like to do in our 40 minutes together or so before we answer questions is to really give you as much information I can on this really amazing new vaccine science that we have out there, and this remarkably rapid production of vaccines that we have. And I'll tell you why it's that way and why it's so remarkable, and you should trust every bit of it. Before I do that though, I want to mention a couple quick things that have changed because of vaccines. And all of us know this idea of quarantining and isolating, and it's getting a little confusing. You know, initially it was pretty easy. You were exposed, you would do this, and you were sick, you would do that. But now we have sort of nuances of this. And I want to just mention briefly before I get into the vaccines, what the vaccines have done to this quarantining and isolating thing. So first of all, quarantining is somebody who's been exposed. You're not sick, but you've been exposed to COVID. You've been exposed to this. So this quarantine idea is to let you kind of sit and percolate. You may or may not get sick with it, but we don't want you out there giving it to somebody else while you're maybe percolating this. And we know that most people got sick within 14 days when they got the coronavirus back early on. We kind of knew this, that if you're going to get sick, you had symptoms within 14 days. But asking people to quarantine for 14 days, especially when you need money for your family, you need to work, it's just really, really hard. So it turns out that 14 days is probably a little bit of a long stretch to make people stay home. So if somebody's exposed to coronavirus, if you're unvaccinated and you're exposed, you can stay home for only 10 days. Most people who develop symptoms will develop it within 10 days. The majority, almost 97% or so, will develop them within 10 days. You can go back to work without any further testing at that 10-day point of day of exposure 0. At that 10-day point, you need to always wear a mask, and we're going to need to do that for a while anyway. I'll talk about that some more later. You need to watch your symptoms, but you don't need to be retested. You can go right back to work. And that's important for those of us that are clearing people to go back to work. They don't need a test for clearance. They can just go back to work. If you want to be at shorter than 10 days, though, you can actually do a 7-day stretch. Now, this is, again, I'm exposed, I'm unvaccinated, I get exposed to COVID, but I can only wait 7 days if I'm willing to be tested. So now what I'm going to do is stay home for 7 days, monitor my symptoms, etc. If I'm still asymptomatic at day 5, 6, or 7, I can get a test. And if that test is negative, I can go back to work. Now, again, we're all still masking and doing all that stuff anyway. I'm still potentially could get sick down the line, but probably not. And that's a safe way to get people back to work at 7 days. That's important because we don't want people having to stay home unnecessarily when they really need to do things like work. Now, isolation is where things have really changed some here. So isolating, we know that symptomatic COVID is now 10 days. It used to be longer. It's now 10 days. So if I can't taste, I can't smell, I've been exposed to COVID, I'm symptomatic, my test is positive, I have it, I've got COVID. My day 1 is when my symptoms started. That counts down to day 10. And then if I'm getting better and I don't have a fever, I can basically go back to work without any further testing. And again, no further testing necessary. Employers are having trouble with that. They want people cleared, but the reality is the CDC is pretty clear on this. And for a lot of very good reasons, that 10-day window with no follow-up testing is important. It's good. There are good reasons behind that. The other thing to know, though, is that that's healthy people. If somebody, and they don't get super sick. If somebody gets really sick, so for instance, say somebody has to go into the hospital for a day, they need extra oxygen for a day. That person is sick enough that they may take a little longer to get rid of that virus. So they need to be basically isolated for 20 days. So that's pretty clear. If you're COVID positive and no symptoms, so say you test positive, darn it, I got the test and it's positive, I don't have any symptoms, you isolate for 10 days and then no further testing is needed. You go back. Now, what if you're vaccinated? What if you're a vaccinated person and you get exposed to COVID? If you're symptomatic, now we know that these vaccines aren't 100% perfect. And by vaccinated, I mean fully vaccinated. You've gotten both doses if it's the 2-dose, you've gotten 1 dose if it's Johnson & Johnson, and you've waited long enough after to be immune. And it's on the slide here what that duration is. If you're truly vaccinated, but you get symptomatic, we know you can still get COVID. So what we'd like you to do is go back like you were an unvaccinated person and do the 10-day isolation thing. But let's say you get exposed to COVID and you're fully vaccinated and you're fine. You have no symptoms at all. You're fine. No quarantine. You get to go about your business. That is really exciting stuff. And so that's another, again, tell people if they're vaccinated, even if they get exposed to COVID, they're still good to go. They're still able to go live their lives and not have to stay home. Now, one other thing that changed recently, and then I'm going to launch into vaccines specifically. They've had changes as far as the recommendations of what to do about a severely immunocompromised adult. So let's say you have a patient who's been on 30 milligrams of prednisone for 5 months because of a rheumatologic condition. That person is considered severely immunocompromised by the CDC. And what they want you to do with that person is basically isolate that person and test them before they can go back anywhere. They can't end their isolation until they're test negative. The reason for this, oh, by the way, in the list of things that are severely immunocompromised, most of these are, we know, somebody on chemo, somebody with a low CD4 count who's HIV, somebody who has combined primary immunodeficiency disorder, which is rare, right? We don't see that very often, but prednisone is common. The reason they're doing this is the variants seem to be coming from this group of people. The variants, they're having this group of people is having trouble clearing the virus. So this is the group of people that may not ever really get rid of it, or it may take a longer time for them to get rid of. So these people just don't clear it as well. So it's, if you have anyone you love, or you have a neighbor, or you have a patient who's on doses of prednisone that are over 20 milligrams a day for 2 weeks, that person needs to get tested negative before they can go back. And that's a new thing, just as of last month. And again, the key here is to try to keep these variants kind of squelched, not let them get out into the community, and get these people healthy before we send them back out. Now, if everyone is vaccinated, I did this 2 weeks ago, everyone in my household, including my daughter and son-in-law who are in the healthcare business, are all vaccinated. And we all had a meal without masks in the same room. And I hugged my grandson for the first time in a year. This is exciting stuff. Tell people they're going to be able to hug their loved ones. And I cried and cried. I was ridiculous. I was crying like crazy. It was just so amazing to be able to have a normal day. So tell people there's a lot of good reasons to be vaccinated. And the other thing that was changed yesterday is, if you have someone you love in a nursing home, and that nursing home has a high vaccination rate, which most of them now in the country do, you can go hang out with grandma. You can go sit with grandma. That is a really, for the people in nursing homes, this has to be nirvana. It's just so exciting. So there's a lot of good reasons to get vaccinated. Now, the vaccine itself, we have had vaccines around forever. Vaccines are miraculous. The nerds that are in those labs that are doing all this fabulous science have saved more lives than anybody on this call ever will. You could take all of the healthcare practitioners in the world. We will never save as many lives as these people did. And we have COVID vaccines now, but let me tell you where we stand. So one of the things I think most people out there have no idea of is the fact that there are over 100 different COVID vaccines being tested out there. At one point, there were over 200. And here's where they are in the trials. Now, this is from a website that I highly recommend to check out. It's the New York Times Coronavirus Vaccine Tracker website. Their reporters on this website are rigorous scientific reporters, and they have in-depth data on virtually every vaccine out there. Right now, there are 42 phase 1 trial vaccines, 32 phase 2 trial vaccines, 22 phase 3 trial vaccines, and in the US, we've approved 3. I would put good money down that we're going to have 5 or even 6 approved in the United States as far as vaccine options by summer. There are 2 more that are going to be presented soon. There's a 3rd one coming down the pike. We've got a lot of these things. So and Anna, what's amazing about this is how quickly it happened. And it happened with beautiful science, miraculous science, science that was primed and ready to go. All the parts were separate, but waiting. And then the money came along and the need came along, and it got produced in less than a year. It is an amazing thing. And we should trust the science. The science has been really rigorous on this. So trust it. Now, I want to mention briefly, before I get into sort of the Q&A part about the individual vaccines themselves, is just to mention that there are with all these gajillion vaccines out there are 4 different categories of them. Now, internationally, all 4 of these are being tested. And internationally, all 4 types of these have been approved. In the United States, we only have the top 2 that have been approved. The viral vectored vaccines, which is Johnson & Johnson, and the nucleic acid vaccines, which are the Moderna and the Pfizer. But there are more out there that are these subunit types, that's Noravax, that are the weakened or inactivated types, which are some of the ones in China. And there's another website that tracks the vaccine internationally, and there are 10 different vaccines that have been approved internationally. So we've got a lot of them out there. The one that we have here is this nucleic acid, and I'm sure everyone on this call is familiar with this. If you've been paying any attention to anything, even just on the news, you know about this. These are Pfizer and Moderna. There are more coming, by the way, but these are the Pfizer and Moderna that we've had out there for a while now, and the impact has been tremendous. They're remarkably effective. The one that was most recently approved here is the Johnson & Johnson. That's the viral vectored. So what these 2 things do is they take, the mRNA ones take this little lipid particle and inject it into your arm. And then it makes it's like a script that tells your body to make spike protein. Your body doesn't like spike protein. It has an immune response. This is similar, but it's now, instead of being in a lipid, it's in a little dead virus. It's in an adenovirus. It's in a little dead virus that they put it into, and they give a little adjuvant to kind of spark it up, inject it into you. And it's a little strip of DNA that basically is the same thing. Now, it doesn't get into your nucleus. It just uses the machinery of your cell to, again, make spike protein, and your body reacts to that. It's miraculous. By the way, AstraZeneca and the Sputnik 5 are also this type of vaccine. The Sputnik 5 vaccine is one that's being used internationally quite a bit. So is AstraZeneca. So know that these are the other kinds of these viral vectored vaccines that are out there. I'm going to briefly mention the vaccines, the vaccines that are subunit, because anyone on this call who's had the hepatitis B vaccine, you got this. So it's basically they take a bit of the protein itself. So in this one, they take a bit of the spike protein, and they basically put it into a sort of a delivery system that gets injected into you, and you now just react to the actual spike protein. Noravax is coming. So I wanted you to know about this type because Noravax is, I think, one of the next two to be approved here in the United States. So Noravax is coming as well. And its efficacy data initially is looking in the high 80s to low 90s. So it's another really effective vaccine. And then the fourth type, this is the type that basically takes the true COVID virus and kind of kills it a little bit, attenuates it, and uses the whole virus and injects it into you. These are the ones that are being done primarily in China. They seem to be effective. We don't have a lot of great data yet. They seem to be pretty effective, and we're going to get more data on this. So just know that there's a lot of stuff out there. It's really, really exciting. Now, what is cool about the United States and what's happened here and how just the world right now is we had only 2 vaccines until Johnson & Johnson just hit the splash because it's 1 dose. Amazing vaccine. There's, again, I mentioned Noravax coming. There's Sputnik 5 is out there. There are 2 more that are coming down the line. So it gives us a lot of options, which is great. But I want to say one thing about these. These were never tested head to head. So we've had Pfizer and Moderna for a while. Johnson & Johnson came after that. Noravax and Sputnik have been going about parallel with that. They were never tested head to head. And they were tested in different parts of the world, and they were tested at different times. So Pfizer and Moderna were tested when we didn't have a bunch of variants out there yet, and their efficacy is great. The Johnson & Johnson was tested in various places in the world where there were some variants, and its overall efficacy seems less, but actually where we care about, it's not. And I'm going to make a case for that for you in a second, because these variants are adding things to the mix that are making people concerned. You know, I got the Pfizer. Am I still protected with what if it's the South Africa variant? What if it's the Brazil variant? What if it's the British variant? You know, am I still protected from these? Well, let me tell you the bottom line. When they kind of looked at all of the 6 vaccines out there where we had phase 3 trials as of about 2 weeks ago, and they looked at, so efficacy in all of these trials is, do you get sick? Do you get symptomatically ill from COVID? That's where the efficacy came from. It's not whether you got infected. You can get infected with no symptoms. They didn't really care about that initially. They wanted to see, did it keep you from getting sick? When they do an efficacy, let's pick 82%, which is what Johnson & Johnson was in our sort of population here. Is that 80? Well, that's not as good as the 95% for Noravax or for the Pfizer, or 94% for Moderna. It's not as good. Well, actually, remember, that's just symptomatically sick. What I really care about, honestly, is I don't want to die, and I don't want to end up sick enough I need to be in the hospital. And every single one of the vaccines that we have phase 3 trials from prevented death and prevented hospitalization. Now, think about what that does to what we care about, not just as individuals and people who love other people, but let's think about how we care about that as a healthcare provider. Anybody who worked in a hospital in the United States, actually worldwide, but in the United States is what I know, in December and January, you know how incredibly horrendous it was. We saw what it was like in Italy. It's been this way around the world. Our healthcare systems just got decimated. It was devastating. Well, look at these numbers. That has evaporated. And let me show you data. The data that's the most compelling right now is from Israel, because Israel has had a remarkably effective rollout of their vaccine. Remarkably effective. And look what happens. This is hospitalizations. So basically the left column here, the blue is non-severe, so people who don't get very sick. The red is people who get severely ill, and the green here is critically ill. So green is hospitalized, some probably in the red are hospitalized. The blue is probably people that are home with COVID. So not vaccinated, the numbers were high. 1 dose, look how far it dropped. After 1 dose, look how far it dropped. Then 7 days after the 2nd dose, it dropped even more. And now 2 weeks after the 2nd dose, nobody's in the hospital. Nobody's sick. That's crazy. That is so remarkable. We will not see this anymore if we get people vaccinated. It is incredible. It's incredibly exciting. So it's not just important for people not dying. That's really important. It's important for the entire system. It helps our healthcare get back to normal. We can do elective surgeries. People have heart attacks can actually get into the emergency department. Your offices can open again. It is really going to have a tremendous impact on healthcare. It's a win-win. It's a tremendous win-win. So where do we stand right now in the United States? I'm going to just focus on the US. And if anybody's international on the call, I know there's one, but I apologize, but I'm going to focus on what I know. So let's talk the FDA approval, we're up to three. So we have a gajillion doses. The doses, right, it's been stuttering, this sort of production problem and this getting it out there problem. It's been stuttering, but we're up to almost 3 million doses a day. We're going to break 3 million doses a day. I guarantee it this week. The rollout has been tremendous. So our goal now is to get people's questions answered, to get their arm to the vaccine and their vaccine to the arm and answer any questions they may have, is to overcome this vaccine hesitancy that's a real issue. It's a real honest to goodness issue. There's some people who will never get vaccinated ever, and they just won't. And that's fine. It's kind of really not fine society-wise, but it's their right. There are people who are all in on vaccines forever. Good for them. This in-between group is the group that I think some of us even fall into, where it's like, I'm not sure, it's a new technology. I'm not sure I really want to do this. I want it out there for a while to make sure it's okay. I understand that. So our jobs, everybody on this call, actually any educated citizen, but particularly people in healthcare, our job is to really answer people's questions. And there's no blaming, there's no, vax shaming or none of this. It's just answer people's questions. And the way to do that is to know your stuff. So let me tell you the kinds of questions that I've heard in giving lectures on this for months and months now, and things that I'm sure has crossed your path, kinds of questions that have crossed your path. So first of all, what most people really care about is it safe? Is this vaccine safe? It's too fast, it was crazy. How could this possibly be safe? Well, I will tell you, the data so far on these vaccines is phenomenally safe. It is almost eye-poppingly safe. Now, the reason that they got this kind of rapid approval, and they're not truly fully approved, they're called EUA, they're emergency use authorization approved. They haven't been approved to the point where the FDA said, we stamp it 100%, it's just good to go all the way across the board. And actually, to be honest, it's just a first step to that final thing. It's 90% of the way there. This is just to get it out there because we need it so much. I think right now the safety is pretty clear. I have no doubt the FDA is going to say, good to go, we're done with those. Let's check these new ones out. And the reason they knew that is that when trials happen, when they get into these phase 3 trials, where there are now tens of thousands of people who've gotten the vaccine, what they find, if there's something really terrible associated with a vaccine, where it really is going to cause a lot of safety issues, it almost always happens if it's a significant part of that vaccine within the first 2 to 3 months. So those lovely people, those fabulous people who volunteered to be in those phase 3 trials were taking that risk. They were taking the risk that there were going to be the group where, ooh, there's enough of you now that if there's a serious side effect here, we're going to see it. It didn't happen. It didn't happen. So how do they know now that it's out of phase 3? By the way, those people are still being followed in the phase 3, but now it's out in all of us. There are millions of doses of this out there. How do they know it's still safe? How are they keeping track? Well, tell people that there are 4 ways that's happening. 4 ways that's happening. One is the one we've had forever, which is the VAERS system. So we've had this forever. So if there's a vaccine problem, say you vaccinate somebody in your practice, your pediatricians are usually hot on this. They know that a physician, anyone can report to this system where they just say, I had a rash 3 days after I got this vaccine. And they just report it. All this is this happened and I got the vaccine. The connection needs to be investigated by the scientists that look at the data. So because think about it. Every single day, vaccine or not, people have heart attacks, people die, people have blood clots. Every single day that happens. Now we want to see is it more often happening in somebody who's vaccinated? So are there trends here where things are happening? So the VAERS system, you can go check it out. It's a database anyone can look at. You can download the entire database if you want to. I check it out about once a week just to see what's there. And the reality is there's really nothing that's popping up more often in vaccinated people right now than non-vaccinated people, as far as the possible side effects that are worrisome, these rare things that now that it's out with millions of doses, is it more than just rare? It turns out it really isn't. It is a phenomenally safe vaccine. It's kind of remarkable how safe this thing is. The other thing is if you've gotten a vaccine, you may have been a participant in this, which is a CDC crowdsourced app. I still get my notifications. I'm now on the every, I think it's every 3 months, but they were checking to see crowdsourcing real time what was happening to people who just got the vaccine. That's how they discovered a side effect called COVID arm. And I'll tell you about COVID arm in a minute, but it was through this VSafe system that they found about the side effect called COVID arm. So this is, again, a crowdsourcing, relatively new. This is new for the COVID vaccine. And then there are two other ways that they're checking. These are long-standing ways to kind of check safety for vaccines. So just let people know there are multiple layers of this. Before it was released, they were careful. And since they're released, they're following it. So let people know that, so that they know that it's not just out there and, oh, well, be gone, it's done. They're following this to be sure. Now, other questions that come up, what are the side effects? So the two things people really care the most about are, what is it safe, and what are the side effects? And that's totally legit. So let's talk about that, because the side effects are similar actually for all three vaccines, but we know a little bit more about Moderna and Pfizer. So when it comes to Moderna and Pfizer, we know, and most of us, if you've gotten the vaccine, you may have had some of these side effects. So almost everybody gets a sore arm. That's really common. And you get that from anything. I got that with my Shingrix vaccine. I got that with my tetanus vaccine. Fatigue is pretty common. People are tired, not wiped out, but just not as energetic as they've been. Maybe a headache, not debilitating, but a little bit of a headache. Aches and pains, chills. So chills are something that actually is about a third of people, and this tends to be young women. So warn people, they may feel really cold. They may not get a fever, but they get chilled like Reggers. This COVID arm thing, which again was discovered through these screening systems of following people with the vaccine, is probably a delayed hypersensitivity response to these vaccines. Moderna seems to be more than Pfizer. We're about 7 to 8 days in. People get on the site that they got the injection, they get a red raised, really tender area. It's not cellulitis. It's just a hypersensitivity reaction. It usually lasts less than a week, often just a couple of days, but common, can be treated symptomatically, doesn't need antibiotics, but it's something that they're not common. It's seen enough to be noticeable, to warn people about. Or somebody calls you and says, wow, I got the vaccine, and what's with my arm? Tell them that's what's happening. Severe symptoms aren't that common. Severe symptoms are basically in about 5%. And I'll tell you the severe symptoms, and all it means by severe is somebody needs to stay home. They have a temperature can be as high as 102. They're achy and they feel fatigued. It's usually a day only. It can be treated symptomatically, and it's usually younger people, often women. Women are having a much more profound sort of symptomatic response to this vaccine, younger women. Older men, less. It's just kind of a spectrum here. So just warn people about that may happen. Now, these symptoms, when they get them, are short. So tell people, because they may call and say, oh, my stepdaughter called and said, I've been sitting in a hot bathtub for 30 minutes. I can't get warm. It's after her second dose. Well, that's a common thing. It's just not going to last forever. It's going to 1 to 3 days max, usually 1 day. And it's just something, just don't schedule work the next day. If that's get your shot when you have a day off the next day. Again, and it's younger people. So there are a few advantages to being old in this world right now. You got your vaccine earlier and you're less likely to have side effects. You're more likely to die if you get the virus. So that's not a good thing, but this is younger people that tend to get these side effects, and it tends to be women more than men. Not clear why, women more than men, and it's usually second dose. So just warn people. First dose skated through, great, good on you. Second dose, just keep an eye out. This might happen. Now, the things people know about that could be really problematic. People are worried about the severe allergic reactions, and these have made the news. I mean, this is something that you hear a lot depending what kind of news station you watch. They happen, absolutely. So anaphylaxis definitely happens. It has now been looked at by the CDC. They're monitoring this at all the sites. It has to get reported. If somebody has an anaphylactic response, it's usually within 15 minutes of the shot, no later than 30 minutes. So that's why I staff one of our local sites, and I'm in the observation area at the Forum here in Los Angeles. This 30-minute, people have to wait. Anybody who has a history of allergies at all goes there because we keep track. Haven't seen anything yet that's been bad there, but it's early. So they watch this, they have them reported. It's considered rare. It's considered no more common than with any other drug or any other vaccine that's out there. So it's a rare thing. There have been no deaths related to anaphylaxis, and it's treatable, absolutely treatable. Now, I will tell you flat out, there have been a couple of people who've been hospitalized because their anaphylaxis was so bad. But it is, again, it is vanishing. It's in the 0.0%, 0.01-ish%, even less if you look at certain populations. So it is a little more common in people with a history of anaphylaxis, but not common enough that it's predictable by any stretch of the imagination. And about a third of the cases happen to people with no history of allergies at all. So it's just unpredictable, extremely rare, really, really, really rare, and treatable. So that's key. Bell's palsy was reported. It doesn't seem to be related to the vaccine any more than the population. And so far, there's been, well, actually probably more than one fatal case of ITP. The fatal case that got reported was a physician who died in January of ITP after the second dose of vaccine. They have been following this closely to see if ITP is related. ITP happens in the community. It happens out in non-vaccinated people. It's actually a rare, in the rare things, it's a relatively common diagnosis that I make in the ER. It's something that we see, and people come in and say, "What's with these weird little red dots all over me? What's happening?" We see this. Now, is it more related to the vaccine? It's not clear. This particular case was considered possibly vaccine related, and it's getting followed. But again, we're talking single cases here. This is extremely rare. And there have been 2 other deaths, including one that was reported just this week in a young mother in Utah. She died 4 days after she got the vaccine, second dose of liver failure. It's not clear whether that was vaccine related at all, but it's being followed closely. So again, the fact that these make the news as individual cases and that there aren't trends in this tells you it's very rare. Now, when it comes to Johnson & Johnson, the vaccine's name is Janssen. The company is Johnson & Johnson. The side effects are very similar. They're basically the same stuff that from before, a little less actually than the Pfizer Moderna vaccines do. And again, more common in younger people. There are very rare side effects that may be of some concern that are getting followed. Guillain-Barré was reported, but not significantly different in the non-vaccinated and the vaccinated population. Pericarditis, Bell's palsy, and blood clots. Now, blood clots are being seen in some patients on AstraZeneca's vaccine, and they're tracking that to see. And some countries have basically stopped vaccinating. This is something that was reported in the phase 3 trials, but in both groups, the vaccinated and unvaccinated. So they're going to follow those. So keep track of that. Well, and again, just know overall, super safe, like incredibly safe, remarkably safe, and really protective. Like what a win-win. Really safe. Side effects are really rare, as far as the bad ones. The common ones we can all manage, and now you're not going to die, and you're not going to end up in the hospital. That's a pretty good balance of things when you want to summarize it for somebody. Now, I didn't get that sick after either of my shots. And an arm was sore, and I thought, man, am I respond? I thought about it. I was like, we all do. Well, it turns out, yes. If you flip around the side effects that were reported from the phase 3 trial, there were a significant proportion of people who had nothing. And yet all of them had that 94% efficacy. So it works. It's just that your immune system doesn't make a big deal out of it. So you don't have to get tested for anything. Yes, you just got lucky. You're one of the lucky people. Now, how about the variants? This is a concern. Okay, this is something everyone is following and everyone is concerned about. I will tell you a couple of things about the variants. Preliminary data right now says that the vaccines all have some efficacy against all of the variants. It's variable. It's not as much against certain of the variants, and we're going to see down the line whether it makes a difference, whether we need booster shots, which my guess is we will, but we'll see down the line. But right now, again, remember that first table, 100% effective against hospitalizations and death, even in places where it was tested like South Africa or Brazil. So far, so good. And they're going to keep track of this. That's where, God bless our public health people and our epidemiologists and our virologists. They're keeping track of this. So far, so good. That's why, and I'll tell you, it's another reason to keep these viruses from spreading like crazy. The more they spread, the more pressure they have or ability they have to become more variable. These variants now can breed other variants. So just know that this is why we need to keep everything under wraps, get this until people get vaccinated so that we don't have it spreading like crazy. I'm worried about spring break, I have to tell you. I'm worried that all these kids that are chafing at the bit to go get drunk and have fun and whatever are going to spread it, especially in states that have no more mask mandates. So we'll see what happens. We'll see if these variants, which are in the states that have lifted their mask mandates, we'll see what happens. We'll see. Hopefully that won't happen. And these vaccines, it's a race. It's vaccine versus variant right now. So hopefully the vaccine will win. Now, when people got their flu vaccine, they want to know, can I get the COVID vaccine? And the CDC basically says you need to wait 2 weeks after the flu vaccine to get the COVID vaccine. And people will say, well, okay, but say I get the vaccine and I get a fever. I get the vaccine and I get a fever. Does that mean I can give COVID to my family? I had a patient ask me this, or a family friend asked me this recently. I got the vaccine, I got this terrible fever. Now I'm afraid I gave COVID to my family. Well, none of the vaccines to date contain any whole virus at all. It's impossible for the vaccine to give you COVID. It's impossible. So if it's just a side effect, if they get that sort of achy fever thing after the vaccine, so good to go. They can't give it to their family. Now, say you have somebody you love who is really, really allergic to things, has had anaphylaxis to penicillin. It's your favorite patient who just has that list of allergies that's a mile long, who's really, truly allergic to these things. They're really worried about getting these vaccines, and I completely understand that. I 100% understand that. The good news is vaccines we're going to have lots to choose from. We do know that anaphylaxis can extremely rarely happen with at least the mRNA vaccines. Johnson & Johnson data is just not robust enough yet to know. Doesn't seem to be, but we'll see as it gets out there. So these people, it's recommended, the CDC recommends that they go ahead and get the vaccine and then come see me in my little observation area, or I'm going to watch you and treat you if you get a severe allergic reaction. I understand people's hesitance though, and now it's just weighing how would it be if you got COVID? Because it's just not a great thing to get. And this vaccine, anaphylaxis risk is low. So and it's treatable. So it's just talking to people. I'll tell you, the only time people should not get the vaccine is if they got anaphylaxis on the first dose. They're not supposed to get it. And if they have a known anaphylactic reaction to a component, polyethylene glycol is the component in the mRNA vaccines, that component. Otherwise, most people can still get it, and we just watch them carefully and take care of them. Now, what about somebody who said, I already had COVID? I'm immune. I already had COVID. Do I need the vaccine? Now, the answer here is yes. And the reason is that we know the immune response to the vaccines. We don't know the routine immune response or how sort of robust it is in someone who gets the virus. We know you have some immunity for a while. We just don't know how good it is. And the goal here is to get everyone kind of on the same page as far as immunity is concerned, and then we can move forward. So we don't want people who've had it losing their immunity and getting sick again. We can prevent that. And then somebody, do I need both doses if I had COVID? I read somewhere that one dose is enough. Well, right now, if the pure science is to get both doses, but they are studying what happens if somebody who's had COVID gets a single dose of one of these 2-dose vaccines. The data looks really promising. The recommendation isn't there yet. So once if the recommendation comes out to say, no, you only need one, good to go. But as of now, it's still recommended to get both doses. Now, what if somebody had antibody therapy? It's like, oh, I had COVID, but I forgot to tell you, they gave me those antibodies. They either gave me convalescent plasma or they gave me those antibodies. What happens then? Well, that person needs to wait 90 days after they got that. And the goal here is to get all that out of their system so that when they get the vaccine, there's none of that left over attacking the vaccine, what the vaccine's doing. It's their whole immune system that's working. That's the goal for that. And then what about somebody's home with sick now with COVID? I have it now. What should I do? I want that vaccine. I don't want to ever get this thing again. What do I do now? They have kind of two choices. One is to wait till they're recovered and then just go ahead and get it then. One is to wait 90 days because the immunity does seem to be 90 days for anybody who's had it. It's up to them. My recommendation for most people is if your number comes up, go get it. Just go get it. Go get the vaccine when you can. And kids. So kids are going to be a pool of potential virus that's going to outlast this current vaccine campaign because right now it's not approved for kids. It is being studied in kids, though. Pfizer has fully enrolled its children's trial. Moderna is almost fully enrolled. It's being tested in some of the other vaccines. We will know for children, and the testing is different in kids. There's a dosing. There's a term for it, but there's a way that they dose this to figure out the right dose in kids. We will know some of this data by the end of summer. We'll know definitely what we need to know by the end of the year. So kids will probably be vaccinated either the end of this year or beginning of next year. And that will get us to our threshold of 70 to 90% of people vaccinated. There are a lot of children in this country. They constitute a good percentage of our population. We need a big percentage vaccinated. So it's coming for kids. So if you're worried about your children, it's coming. Now, what about pregnant women? So these vaccines were not studied in pregnant women, but women got pregnant who were in the studies. So So I would tell you right now, ACOG, the American College of OBGYN, has come out with a flat out statement saying that they recommend women who are pregnant get COVID vaccine. We know that pregnant women, if they get COVID, get sicker compared to a non-pregnant woman the same age. They have a higher risk. And a woman with COVID has a higher risk of losing that pregnancy. So this prevention would be nice. There's no effect on the baby. And in fact, the mother's antibodies get into the baby. They're transplacental and in breast milk. So babies will get the mom's antibodies. So it's kind of a win-win. But they should talk with their OBGYNs on this. And then what about somebody who basically says, I don't really want both doses. I only want one dose. Do I really need both doses? I saw that one dose looks pretty good. Is that good enough? Well, right now it's recommended to just do the whole thing. And the reason for that is they know exactly the response because they tested it after 2 doses. They know your immune response. They know your decreased risk of death, decreased risk of getting sick. It wasn't tested at 1 dose. It is now. It's being tested now, but we don't know. So right now, 2 doses is recommended. There is a natural experiment going on in the UK where they've actually extended dosing durations. They've given 1 dose to people. There's a natural study being done in the UK. We'll see what happens there. But overall, right now, here, it's recommended to get both doses. Now, what if the second appointment isn't exactly spot on? 3 weeks for Pfizer, 4 weeks for Moderna. That's fine. The CDC has given this window of 42 days for either of the 2 vaccines to go out to. What you don't want to do is go too early for the second dose. You're priming your immune system to really like rev up on that second dose. You haven't given it a chance to kind of percolate enough if you do it too soon. So 4 days early for the second dose is the earliest you should get it. 42 days out. And if it's longer than that, honestly, it's probably fine, but that's optimal. And then what about, people want to wait? It's like, I heard about that Johnson & Johnson. I want that instead. And you have Pfizer today. I want Johnson & Johnson. Well, that's their choice. It's perfectly fine to do. We have choices now, but the key is to get vaccinated as soon as possible. So, and people will be able to ask now. There's some clinics that have all of them. Would you like Moderna? Would you like, it's like a menu. Which would you like? People can choose some places, but if they don't have a choice, get what you can. That's helpful. And can they mix vaccines? Not now. But they're testing this. So Sputnik and Novavax are testing together. Sputnik and AstraZeneca are testing together. We'll see, but right now we don't know. So right now it's not recommended. Now, what about somebody who's immunocompromised, somebody who's a chemo patient, somebody who's on those immunosuppressant drugs? So what do we do? Well, they didn't test it in those people, but the CDC is strongly recommending that those people get the vaccine because if they get COVID, they do poorly. We know they do poorly. So the key here is to protect them. And the reason it's an issue, so somebody said, well, why am I different? Why am I different? I know I can get sicker, but why is the vaccine different for me? Well, they're not sure of the immune response in somebody who's immunocompromised. We don't know for sure how efficacious it is. It wasn't studied, but it's bound to be some. So that's why the CDC is recommending it. And that person may say, well, then should I get my antibody tested? Should I see if it actually did anything? Well, that is not recommended for anybody. I don't care if you're immunocompromised or not, because what it's doing is freaking people out if they don't have antibody measurable. No, our antibody tests aren't perfect. Some of them test the wrong kind of antibody, not to spike protein, but to something else. There's a T cell response you have in addition to an an antibody response. Just don't go there. You're going to freak yourself out for something unnecessarily. Now, a few last things, then I'm going to open for questions. Some people will start with questions like, well, I heard it's going to get into my DNA. It is physically impossible for these vaccines to get into your DNA. It is physically impossible to do. So reassure them that just can't happen. The way these vaccines are made, it is impossible to happen. And the thing I'm hearing now that has gone rampant on the internet, in social media, is young women of childbearing age saying, I don't want it because I heard it can make it so I have trouble getting pregnant. This is 100% not true. There is no effect on a woman's ability to be pregnant. And it comes from a story that had a thread of scientific truth that was just researchers being due diligent that got out into the wild, got blown out of proportion. It has nothing. It's been proven not to cause this problem, but it has a mind of its own, this whole social media blow up. So it does not affect female fertility. It absolutely doesn't. Some people may say it's going to give them COVID, like people say the flu vaccine is going to give them the flu. Well, it doesn't. It can't. It's not live vaccine. It can't. But people who've been vaccinated can get COVID. How does that happen? Well, sometimes they're not fully immune yet. They can get it because they're incubating it or get exposed before they're fully immune. It's not 100% effective. We know that. And variants may affect its efficacy. So you may still be able to get COVID. It's just much less likely. Now, what about our virus tests? There's talking about all these tests for kids that are going to school or tests for kids, people going to work on just a surveillance basis. Does the vaccine change those tests? Absolutely not. Those tests, those nasopharyngeal swab, those are 100% reliable. The vaccine doesn't change those. And then the last couple of things people ask. I heard that the vaccine reduces transmission. Well, what's exciting is it probably does. We were worried that you could still get infected and give it to other people. There is still a chance of that, but it does seem to decrease your infectivity if you do happen to pick up the virus. So it's not 100% though. So the mask thing, is that still real? Yes. once this is under control, we have a steady state of vaccines, vaccinations, where the variants are, where they're going, testing. We have some steady state. We'll be able to chuck those things, but not for a while. What the vaccine is doing right now is adding another piece of cheese in the Swiss cheese. And we're basically knocking out the number of viruses that can make it through these sort of holes in the Swiss cheese, but we still need these bits of Swiss cheese for a while. And then all of us healthcare workers, all we healthcare workers out there that go looking like Martians to our jobs, we still have to wear PPE. People are going to ask you crazy things. You know, I think it's just the flu. We know it's not the flu. We just know it's not the flu. There's a million reasons this isn't the flu. Pick anything on this slide. It is not the flu. It's 10 times as deadly. It's just not the flu. So I don't know how to counter that except with science, with just telling people the data. And then the really nutty things that people really do think, like nanobots and trackers, and I don't know what to do with that. And the vaccine is not mandatory. I saw somebody wearing a t-shirt saying, you know, no mandatory vaccines. This isn't mandatory. This isn't mandatory. Nobody's making you do this. So the last little bits, and then we're going to open to questions. Things we don't know. We don't know whether people should wait for future vaccines. We know there are more coming. We know that. And at some point we may say, you're 22 years old, this is the best vaccine for you. You're 75, this is the one for you. We just don't know yet. So yes, there are more coming. People should just get a vaccine when they can. Safety issues look pretty darn good. It's actually remarkable. And we'll just follow. That's the key, right? We'll follow all of this. This is the money question. You know, how long is this immunity going to last? We don't know. We don't know. And it's complicated. We know that antibodies may fall off, but T cell immunity is brilliant. It's your memory. It's fabulous. And we don't know what's going to happen here. So we'll see. And again, we've only had this virus for a year. We have a lot of information. We just need some time to know. As far as carrying and give it to other people, I think that's going to drop significantly as more and more people get vaccinated. It's going to become less of an issue. So keep your ear to the ground on that one. So right now it's variant versus vaccine. We're going to have to stay cautious for a while. It may be bumpy. We'll see if we have another surge. I'm a little worried. We'll see. Hopefully not. Slowly but surely, we're unburdening the healthcare system. We're getting kids back to school. I have kids at my local school as of this last week. It's so exciting. It's fabulous. We're going to fix the economy. We're going to actually have restaurants open. We're going to have movie theaters open. We're going to be able to go back and socialize. The last thing's probably not travel so much, but big gatherings, but they're coming. They're coming. It'll happen again. Sporting events, concerts, it'll happen again. It's nice to have good news. There is great news. These are really effective. They prevent death and hospitalizations. They decrease transmissibility, not to 100% yet, but almost. And there's a ton of them now. There are 240 million doses are going to be available by the end of this month, within 3 weeks, less than 3 weeks. And the goal is, and we'll have enough vaccine to have everybody vaccinated by July 1st. Every adult, everybody who wants one, who's an adult, will have one by July 1st. This timeline that just came out within the last month or so had us all kind of fully vaccinated, you know, up to a level of sort of semi-normal life by the end of November. That was giving 1.4 million doses a day. We're going to hit 3 million this week. This is where we're going to be. We're going to be able to start gathering safely in July. It is incredibly exciting stuff. So it is positive. This is a brilliant light at the end of the tunnel. And the key now is to get that vaccine into as many arms as we can. Thank you for your time. I went 45 minutes, a little bit over, but I think we have time and I will answer any and every question you have. Thank you for being here. There are 25 of you. It's great to have you here, and I'm going to open to questions.
Thank you so much, Dr. Birnbaumer. You know, it's a great, one of the best discussions and lectures I've ever heard about the COVID vaccines, and I really appreciate the clinical scenarios because I think that touches on a lot of the discussions we have with our patients, colleagues, and family. I do have a good amount of questions off the air and on the air. I'll start with some of the live questions. I tried to lump them up so they are kind of talking about the same topic. So we'll start with PCR. How accurate is PCR?
So it depends on the test. PCR in general is a good test. So it's better than the antigen tests as far as diagnosing. Each test is a little bit different, and the rapid tests are not quite as good as the ones that take a little bit longer, but they're better than they were at the beginning. So at the beginning, we had over 200 different kinds of tests out there, 200. Some were terrible and actually got pulled from the FDA. The FDA just pulled them all because they were terrible. These are much better. The ones that they're going to do at home which is what they're trying to do, is push these out into the home so that people can test their kids before they go to school. You can test yourself before you go to work. Those are going to be reliable enough in asymptomatic people to be great screens. I think the difference between how you use a PCR test is symptomatic or asymptomatic. Symptomatic, and it sure sounds like COVID. I can't smell, I can't taste. And that PCR is negative, I don't trust the test. There are enough false negatives, I don't trust the test. If it's just a screening test for somebody and it's negative, they're not symptomatic, that's probably fine. So a lot of it depends on, and if they're exposed and it's negative, it's the day one. That's, first of all, they shouldn't get tested day one. Anybody's exposed should get tested day 3 to 5. They should wait long enough to get the virus in them that's measurable. So that's one reason that they're false negatives. They're tested too soon. So day 3 to 5, if it's negative day 3 to 5, they're probably good to go. The tests are good enough to use as screenings. If they're symptomatic though, if it sounds like COVID, it's COVID. I don't care what the test says.
Okay. Got it. So if somebody had the disease, how accurate is it? You think the PCR?
It depends on the test. There's low as 60% and as high as 95.
Okay. So how about somebody who got COVID, and how long will they still test positive with PCR? Let's talk, I think just to simplify, let's talk PCR and nasopharyngeal PCR.
Okay. So this is a problem. This is the reason that the CDC says if you are improving like you were expected to, they don't want you retested before you go back to work. Or if you were exposed, you tested positive at one point, they don't want you retesting at day 10 if you don't develop any symptoms, because there are false positive tests where people still shed virus. They still will have positive tests. So if somebody's improving clinically, the problem is that they're no longer infectious. Even if it's the virus, they're no longer infectious if they're improving clinically. The person that's not improving clinically, that's concerning. And I'll tell you, the bigger concern right now is now that we have people who got COVID the first time 9 months ago. So we have people now who have been recovered for 9 months. They were in that first batch of people. That reinfection can happen. We know it can happen. It's rare so far, but at some point we're going to start to see reinfections. That is a concern, and that is a problem. So if somebody sounds COVID-y, but they've been asymptomatic for 9 months, especially if they were negative in that interim, that person should get retested. That is a person who may have a reinfection with COVID. And that's something that we're trying to, and I'll tell you, if somebody's vaccinated, fully vaccinated, who sounds like they have COVID, please test them and save the sample for variant testing. They're doing genomic testing on that to see what's the breakthrough of variants if it's a variant.
Okay, so going along those lines, so somebody gets COVID, and then one question the audience had: why not just get one dose of the vaccine? Do we have data on that?
No, we don't. And I think the only concern there is your body, is it going to affect the efficacy of the vaccine to have your body doing two things at once, or is it going to affect the outcome of COVID? What's interesting is that there's very anecdotal data right now that COVID in long haulers, they're actually getting a little bit better after their vaccine. And this is strictly anecdotal so far, but they're tracking this to see, is it some sort of altered immune response, ineffective immune response in these long haulers that needs something that's like a booster? Is that what's wrong with long haulers? And is if you gave the vaccine at the same time as getting COVID, symptomatic COVID, I would consider that symptomatic, would it affect your immune response to either? So I think the safest thing to do is to wait to recovery, so that we know that the vaccine doesn't make anybody divert their immune system or from recovering, and then give the vaccine. I think it's the safest way. We don't know yet enough data. And I think the main thing is to be as safe as we can with our approach to COVID, because we don't know everything yet.
So somebody gets vaccinated. Somebody's still going along the lines of same category of questions as far as somebody who's COVID positive. So somebody COVID positive, and they're done with the disease, they test the antibodies, they have high titers. And they're questioning why they need to be vaccinated.
So the reason they need to be vaccinated is we know the response to the vaccine, and we can follow the initial phase 3 trial people to see how long they're immune. The problem with people's response to being sick with COVID is that their antibody response, which is what we followed so far, not T cell, we've been following antibody response, is variable. So it turns out that the sicker people are, the more robust their antibody response seems to be as far as lasting. The less sick, it doesn't seem to be measurably lasting as long. What that means to whether you're truly immune or not, we don't know, because we don't know what their T cells did. But the reason here is we know what happens to you if we give you a vaccine. We're not sure what happens to your immunity if you get sick with COVID, depending on the range of sickness. So it's trying to get a steady state. Everybody on the kind of the same page to start is the reason that they're recommending vaccines. That way we know you're immune. And we know, because we're following everybody else, how long you'll be immune and when to get a booster and when you should get kind of caught up with everybody else.
Is there any utility to do antibody testing for in general, or maybe in specific groups, as far as the elderly patients, immunocompromised?
Is that related to the vaccine or separate?
Related to the vaccine.
So it's the CDC specifically recommends not. And the reason for that, I think, is freaking people out more than anything. The antibody response doesn't seem to necessarily correlate with whether people prevented symptomatic infection. So not having measurable antibody with the tests that we have, which are variable in quality, didn't correlate with whether the efficacy was the efficacy, whether they measured antibody or not. So the goal here really is, it's not the antibody we cared about in these studies. What we cared about is, did you get sick? And so that's the point here is, if you don't have an antibody response, it doesn't mean you're not immune. And they're not going to give you a third dose and a fourth dose and a fifth dose. You will be in that 94% efficacy, and in that 100%, you're not going to die or get in the hospital group. So these are the nuances of science that I think are really hard to translate to the public, to explain to the public what really was studied and what we get from these things. That's the sciencey part that's a little hard to explain.
And I think I want to underline that also for us as physicians, and also for everybody else. I think you've touched upon this. Immunogenicity, it's not only measured by antibodies,
right?
Because you still have your T cells, that you can get somebody who have the T cell memory for the COVID vaccine, and they can be tested negative for the antibodies, but they still have the code, right? Exactly. To code the antibodies when they get exposed to COVID. So I think that's important. You mentioned that in your talk.
One of the encouraging things that came out, I read Science and Nature magazine threads because they have really good data on this. And they've looked at the T cell memory of people who got the SARS-1 antibody or SARS-1 and survived. There was a SARS-1 antibody. They just never needed to produce it because SARS-1 went away. Their T cell memory is 18 years old.
Wow.
They have measurable T cell memory. We're now 18 or 19 years. It was 2002. So we're 18, 19 years past that. And they still have measurable T cell immunity. So it's very promising.
So also talking about immunocompromised patients, we have a question from the audience. A patient who had kidney transplant, obviously an immunosuppressant, they got the vaccine. 2 months later, the antibodies were tested for whatever reason, they were negative. What do we do in this scenario?
Don't bother testing. That's exactly why don't bother testing.
But what do we tell the patient?
That I would basically have them live their life as a vaccinated person, if it's the right vaccine. So they need 2 doses, right? If it's the Moderna or Pfizer, the Johnson & Johnson is going to be 1. Make sure that they got the appropriate dosing. But at this point, I would have I would still have them be safe because they're immunocompromised anyway, just in general. But as far as COVID is concerned, wear a mask. Everybody else is still doing, but I would consider them still vaccinated people.
And regarding the same group of patients, immunocompromised, there's a concern somewhere in the media and on the internet that maybe those patients should get one sort of vaccine versus the other.
Not clear.
As far as the adenovirus, the vector virus based vaccines versus the mRNA. Any data on that?
No. So the adenovirus vaccine, so the bottom line from the CDC is, because it is a dead virus, it is a non-infectious virus, that immunocompromised isn't the group that's the type of vaccines that are concerning for that group are the attenuated vaccines. That's why MMR is an issue. That's an attenuated vaccine. So that's why we worry about the MMR vaccine in people who are immunocompromised. These have no infectious component to them, none. So far, the ones that have been approved should be fine in immunocompromised people. If we ever do get some of the vaccines that have been tested in China, which are attenuated virus vaccines, I think that group will not be recommended in people who are immunocompromised.
And I think we talked a little bit about this question as far as vaccine immunity. How long does it last? And the question whether we need a booster or not, I think you touched on.
Right. So I'll just retouch on that briefly. So we don't know how long it's going to last. And we just haven't had time yet. But I would put money on needing boosters. And the reason for that is that with the variants now kind of worldwide, and they're not going to stop, the people will travel. They're going to continue to be kind of spread around until we get the world immune. And that could take as long as 2024 to get enough vaccine out to the world. There will be variants that move around. And I think we'll need boosters. The question is just going to be when, and just so you know, Moderna's already tested its booster. They already have one and they're testing it. Pfizer has another one. And the thing about the mRNA vaccines is they can produce a booster in 6 weeks. They can change their technology in 6 weeks for the new variant. It's like magic. It's like magic. So we'll have them and they'll be pretty quickly produced if we need them. And I suspect it's going to be probably in about a year or two after your first vaccine, probably 2, that you'll need a booster unless something major changes with variants. If suddenly the Brazilian variant becomes worldwide, then we may need a booster sooner.
So another clinical question, somebody was from our audience was asked by their patients, well, I got exposed to the whole virus and I got the full symptoms. And now, even though I went through all that, I'm still not considered fully immune. And now you're going to give me a part of vaccine, and now you tell me that this just getting inoculated with the mRNA and getting exposed to the M spike is going to give me full immunity versus full exposure. How do you explain that to the patient?
Okay, so I'm a little confused with the question, but I'll try to parse it out. So what I'm hearing on the question is somebody has COVID, symptomatic COVID, and is recovered. So that person is immune for at least 3 months, probably 6, but at least 3. So the CDC has kind of picked 3 as for sure to be safe. And then that person is recommended to get a vaccine.
Yes.
Is definitely recommended to get a vaccine. What our vaccines do right now is produce spike protein, the one that allows it to stick to you, not the M protein, which is once it's in you, it does its thing. This is to keep it from even getting into you. The reason for that is to have you guaranteed a durable immunity that's predictable from what we know about the vaccine. Your immunity durability from being sick with COVID, we don't know. We don't know.
I guess the question is, the patient is asking the clinician is, why am I considered not fully immune, even though I got the full clinical picture and full exposure to the virus?
Well, no, they are.
I mean, like a long-term immunity.
Because we
why is he not? Why is given a part of the virus gives you more immunity? I mean, just to simplify, why given a part of the virus is considered to give you longer and more lasting immunity than being exposed to the whole virus?
You get a massive production of spike protein when you get this vaccine. It's short duration. So you have this mRNA that goes into your muscle cells and your deltoid. They all produce spike protein, stick it on their surface, and you get this gigantic production for a short amount of time of a lot of spike protein. Your immune system goes berserk attacking that. You have your helper cells, you have your memory T cells, you have your cytotoxic T cells, and you have your B cells making antibody. And you do that twice. So you prime the pump, and then you blast it again 3 or 4 weeks later. And now you have a phenomenally robust immune response. And predictably response versus we don't know predictably what your COVID did to you. We don't know. And we know with ranges of illness from people completely asymptomatic to dead, that people's responses are very variable.
I think that exactly answers the question. As far as what's your comment regarding, countries in Europe, mainly Scandinavian countries, recent Bulgaria and Taiwan, stopping the AstraZeneca vaccine due to thrombosis?
So I think that's actually probably smart. The only way these vaccines are going to be accepted is for everyone to trust that as we learn about them, as we know more about that, they're not released early, when they're unsafe, that if something pops up along the way, we stop and assess the situation. They did it during the trials. If something came up during the trial, they stopped the trial, really looked at everything before they even continued the trial. So it's the same thing when it's out in public. So this is, I think, a smart thing to try to make sure that the population is safe. Whether the clots are real or not, I don't know. This is something that it's worth watching. We don't have AstraZeneca here, so we don't have our system doesn't have it in our system here to look at the data. But there does seem to be a little bit of an increased trend of clots. And I think it's the countries just trying to keep it transparent, make sure the population is safe. And if they do open it up again to give the vaccine, just to be able to say, and here's what we know about the risks. That's key, right? Why would you take anything unless you're sure to trust that they're going to tell you the right thing? They're going to tell you what's actually happening. I think it's a trust thing.
So you touched a little bit on this as far as immune response to the vaccine. You mentioned that younger people have less likelihood of getting symptoms, side effects after the vaccine. And does that correlate to immunogenicity and production of antibody or immunity?
So younger people actually are more likely to get, and I'll tell you to get a side effect. And the frustrating thing about that is they're also less likely to die, right? So take a 24-year-old who's been locked up at home for a year, who wants to go drink and party and go to bars and go dancing and go crazy. And they know that they're not going to get that sick, most likely from COVID. And they know that their risk of side effects is probably about 25 to 50%. They're going to get a side effect. It's like, why would I get a vaccine when I'm going to get sick for a day? It's going to make me feel sick for a day when I can get this virus and I'll be fine. It's like a cold. Well, it's not like a cold, even for young people. They can get pretty darn sick with COVID. They can die from COVID. In fact, I think we'll see disproportionately more people in hospitals that are young who are dying because the old people are vaccinated now. We're going to see more younger people in the hospital as that happens. The other thing, though, to tell younger people about this vaccine is that it's going to give them a chance to go visit grandma or their friend's grandma and not worry about getting that person sick. They're not going to take the virus with them. They're going to, as we all get more vaccinated, it's going to allow people to be together. There is nothing harder, and I don't know if anybody in this call has had to do it, than trying to console a family member who did something stupid and then brought the virus home to a family member who dies. That's
Exactly.
a guilt. That's a guilt they're going to carry forever, and it's 100% unnecessary. 100%.
How about a pre-treatment and post-treatment after the vaccine?
Good question.
Tylenol, NSAIDs.
Mm-hmm. So pre-treatment, post-treatment, no problem. Pre-treatment is probably no problem. And what the CDC is recommending is don't pre-treat, because the reality is most people don't have anything serious anyway. So you're just wasting medicine. But if you do develop symptoms, then go ahead and take the antipyretic, take the Tylenol, if you're achy, take the non-steroidal. Whether it affects your immune response is strictly theoretic. It's an empirical question. It was never studied. That's why they're saying don't, if you don't have to, don't take it. It was never studied to see if it has an impact on you. There's no logical reason I can think of, medical reason, that those would affect your immune response. So I think just use your judgment. If you're feeling really achy and horrible and you have a fever after the second dose, go for it, take it. I just wouldn't pre-treat, there's no need.
Regarding the J&J or Janssen vaccine, are you aware, does it contain polysorbate? There's a question regarding that. Okay.
It does. And so the recommendation that came out, by the way, there's a thing called COCA, C-O-C-A. The CDC does they're short, they're 30-minute informational programs for physicians or healthcare practitioners about these vaccines. And there's a COCA, 30-minute COCA on the J&J vaccine that came out just a week ago. Just Google COCA J&J vaccine, and it has all of this in there. And one of the things that is in its makeup is polysorbate. So it is, if someone is allergic to polysorbate, they shouldn't be getting the J&J vaccine. Anaphylactic, not just a little bit allergic, they're anaphylactic to polysorbate.
Okay. And a couple other questions about PCR. How accurate is it? We said it's highly accurate. And as you mentioned, the question states, does it get to be effective if you vaccinate or have the disease? Obviously, the answer is no. How about travel? And, you're traveling. I know the PCR now is a requirement. Is that scientific or is that just based on policies?
So I think what they're trying to do is the same with travel. This, like, you mean talk about getting tested before you get on an airplane, that kind of travel. Is that what the question is? Testing?
Yeah, the question is for people traveling and don't have symptoms, they still ask for PCR.
They do.
In your opinion, is this scientific or practical?
So I think it's a little bit of both. What they're trying to do is the same thing that they're trying to do when kids are going back to school, when people are going back to big work plants where there are lots of people working close together. What they're trying to do is the positive test in the asymptomatic person, that person they're trying to take out of the pool. They're trying to, that person can spread it and not even know they're sick. Remember, 40% of people with COVID never get sick. They never get a symptom, 40%. So what they're trying to do is catch those few people that would come through the system that might be carrying the virus, have the virus, and not even know that they have it, that could give it to an airplane. You're in an airplane for 5 hours, 10 hours in this little tube up in the sky. They're trying to keep that from circulating in that system, or in a school. They're trying to do it that way as well. So there is some science to that. If it's positive, that's probably positive. If it's, I'll tell you, the people that are problematic are the people who are lying about their symptoms and still trying to get on airplanes. Those people are spreading virus, no question about it. They're getting arrested in Hawaii. You do that, you go to Hawaii, you get arrested. They will throw you in jail when you go to Hawaii if you do that. So don't do it when you go to Hawaii. So I think the virus testing actually makes some sense. I'll tell you where it's going to be a problem. Not a problem, where it becomes a little iffy is, so say I travel, I'm fully vaccinated. I've been vaccinated since January. And I say I want to fly somewhere. Well, I'm immune. Okay, I'm immune. I'm immune. Can I carry the virus? Yes, but probably less than other people do. Why would they test me? What's the point of testing me? And I think they can't just do it, well, you're vaccinated, you're not. They can't do that. It's too nuanced. So I understand these blanket policies for travel. There is some science to it. Some of it's just policy, but there is some science to it.
And was there any data as far as the response to the vaccine in the studies in the elderly population? Was there any analysis about that?
The response in the elderly?
Yes.
There was. So they broke out. So first of all, the elderly are very protected by this vaccine. The antibodies that they measured in the elderly were less robust than they were when they did measure in the studies themselves, were less robust than the younger people. But the antibody response for older people is less robust than younger people, period. So that's not surprising by any stretch. However, the protection for the elderly was astounding, astounding. It really prevented death in the elderly and severe illness in the elderly. Its efficacy is remarkable. We're seeing it, right? We're seeing it.
Yeah. I'm going to end up with a couple questions. So here it is, January, Dr. Birnbaumer, and you offer 3 vaccines. Which one would you choose?
That's a good question. So it depends on my situation. If I were 25 and healthy, I would choose Johnson & Johnson. I want it once. I don't want to have to come back again. I don't want a bunch of side effects. It's going to be efficacious for me. I would probably choose Johnson & Johnson if I were young. Okay. The older I am and the sicker I am, if I had a choice, I would choose Pfizer or Moderna.
And that's because you get 2 inoculations of the mRNA and higher exposure to the M spike protein, right? Is that the reason?
Yes. Theoretically, yes. I think mainly because it's been out there longer, and I know it's efficacious in the elderly. When we get more data on Johnson & Johnson out in the wild, now that we have it being given to people across the board, and we can really compare, does it do like it did in Israel to get the Pfizer vaccine in Israel and have nobody hospitalized 2 weeks after the second dose? So is it going to be that good with the Johnson & Johnson? And again, we just don't, it's 3 months behind, 2 months behind. So it doesn't quite have the same amount of data. It may end up being where that's just fine for everybody. My goal is to keep people from dying and people from going to the hospital.
Which makes sense. Well, one question that popped in right now, we talked a little bit about this. What's the latest news on vaccine preventing transmission of COVID?
Yeah.
And not just preventing the disease itself?
Right.
You
so
touched
on this. I'll tell you,
the
study that came out this week that got everyone's attention, Pfizer put out data this week. I think it's in the New England Journal. It's all very sciencey sounding. It has the vaccine and its vaccine name, not the Pfizer vaccine. It's all very sciencey sounding. SARS-CoV-2. They looked at infectivity of people who'd gotten the vaccine. Their infectivity, and they saw it dropped about by 2/3. Wasn't 0, but it dropped by about 2/3. Now there's some question about the data. It's a convenient sample. It wasn't really looked at comparing a non-vaccinated to vaccinated or 2 vaccines to each other, or it was just sort of a convenient sample. They just sampled people. But I think across the board, and it makes sense that we're going to find that you just don't get it as much either, but it's not going to be 0. And what I think people think that all the vaccines we've had so far, all these viral vaccines we've had forever, means that you never get the virus that you're exposed to. Well, that's not true. You just don't get sick from the virus that you get exposed to. The viruses are still out there. They're endemic. They're still out there. They're still us as a host. It's still out there. So we haven't completely gotten rid of all those viruses. This one too. So it will still be around. We'll still all get some of it. We just won't necessarily pass it off as well. I wish I could say you are completely home free. You won't ever infect anybody. You can just do what you want to, but we're not there yet.
And I think that goes to the point that everybody who has access to the vaccine needs to get it, because if you have two people, one of them is vaccinated and the other person is not vaccinated, the vaccinated person can still pass on the disease to the person who's not vaccinated and get them sick. I mean, this is a very conveniently selected group of patients, and even in that study, it was only 2/3. So that tells you that, you know, the real life data is going to be even much higher than that.
And the other thing I'm finding at the forum, when I go to the forum site, I talk to a lot of people in their cars. They have a lot of questions like, okay, I've been vaccinated. Now can I go do this, that, and the other thing? People need to understand that what's happening when you're a vaccinated person is your responsibility gets transferred from protecting yourself, which is what a lot of people are worried about, to protecting somebody else. You are a lucky person. The likelihood of you getting sick is really low, but you could hurt someone else. So that mask is now very important for that other person, any other person who's not vaccinated yet around you, not just loved ones, but somebody in the grocery store. So the onus changes. It becomes now you being a careful person for other people, and making that a priority.
That's a great point for us, as majority of us in this panel, this discussion are vaccinated. We can't let our guard down, and at this point, it turns from guard for us. It's a guard for everyone around us,
right?
Really, especially with our exposure. I mean, we're still highly exposed.
All the time. And I think it's a respectful thing, right? I think respecting other people is so important. And I respect their health and I respect their livelihood, and I'm not going to get them sick. I'm just not going to do it. I respect them.
Another question, Harvard study says no benefit found for early anti-clotting therapy in severe COVID. What should our approach be regarding the clotting issue in COVID?
Oh, the clotting issue. So this has been the bane of our existence, right? When we finally figured out that COVID was causing all these crazy blood clots, like crazy, crazy blood clots. Everybody got high dose everything. Firstly regular dose everything. Then we went high dose everything, trying to figure out how do we prevent these PEs and all these mini microclots everywhere. It was just wacky. People were getting arterial clots. It's like, what is happening here? We know that the drugs we use to treat clots are also the most lethal drugs we have. They are flat out the ones that cause the most deaths as a drug category. So the key here, I think, is wait until the clot happens and then treat the clot. And that's what I'm seeing as the bottom line in most of these things. I'll tell you the harder thing right now is that some people are still more prone to clot after they've been discharged, and what to do then. And there's some research being done on discharged patients with COVID, and do they need, sort of prophylactic anticoagulation for 6 months or so? And nobody knows that yet. So I think right now the bottom line is if they're clotting, treat them. If they're super sick, don't necessarily treat them. And again, the reason for it is the harm from the drug is probably worse than the anticipated possible clot is.
I'm going to end up with this last question. Seems to be every time I want to end it up, I get more and more questions. That speaks to the enthusiasm and the elegance of your speech. So thank you so much again. Do you think that we are at a point, as far as medical practices, for us that work in outpatient settings, to relax the restrictions, and as far as screening and pre-procedure testing for COVID?
No, but it's coming. So I think right now everyone is so anxious to be done with this insanity. So I got my haircut yesterday at a hair salon. First time in a year. They are so sick of signing people in and having their temperatures. And I get it. I go to a pottery studio. I have to do it at the pottery studio, for heaven's sakes. Everyone wants to be done with that. We're almost there, but we're not there yet. So just hang in there. I think, honestly, by the end of the year, for sure, probably by the end of summer, we'll have the ability to say, these kinds of screening things we don't need to do anymore. It's just there's not enough of it out there anymore to make that an issue. We've got a little while to go though, and let's see what happens after spring break. We're going to have this sort of 6-week rolling spring break period to see what happens, and then we'll know. But hang in there. I think it's going to happen for sure. It's just when. And I think our job as medical people is to be as safe as we can, to keep our patients as safe as we can. Because we're sort of the scientists and the health caregivers and trying to keep that as safe as we possibly can.
Well, I think the message is get vaccinated, get everybody around you who can be vaccinated, and so that we can get out of this and go back to our normal life prior to
hug
COVID.
Each other. It's so great to hug each other. I have my book clubs getting together for the first time next month. I'm so excited. We're all vaccinated. Wow. I'm so excited.
Thank you so much, everybody, for taking time on your Saturday. Thank you, Dr. Birnbaumer, on this very elegant and much needed talk. And thank you for joining us at the Syrian American Medical Society presentation. And looking forward to more future talks. And have a great rest of the weekend, everybody. Thank you so much.
I'm going to go see my grandson. Bye, everybody.
All right, sounds good.